And this is the April 2023 Maryland Healthcare Commission meeting. This meeting is a hybrid commission meeting. There are several commissioners here in room 100, and the rest of the commissioners are participating by Zoom. Given this is a hybrid meeting, the additional ground rules continue to apply. I begin the meeting with a roll call of commissioners. During the meeting, I ask commissioners and presenters to identify themselves before speaking so that commissioners and members of the public will know who is talking and will have the same knowledge as those of us here in room 100. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask the commissioners and presenters to mute their electronic devices when they're not speaking. I'd also like to ask commissioners attending remotely to avoid putting substantive comments in the chat because it can be difficult for those of us here in the room to see the comments. MHCC posts documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the commission's website and various social media channels. Okay, call the roll. I see Commissioner Bhandari. I see you online.
Yeah.
Commissioner Boyer. Commissioner Boyle. Oh. Commissioner Brumbot. Commissioner Bazinski. Yep. Commissioner Cheatham. Commissioner Jensen. Commissioner O'Connor.
Here.
Welcome. Commissioner O'Grady, I could see you on the screen. Welcome. Commissioner Ojikutu. Commissioner Wang.
Here.
Welcome. And I see Commissioner Wood. Welcome. Conversation. So welcome. We have a long agenda item. I think we can move through pretty quickly. So hopefully it won't be a terribly long meeting, but despite that, we do want to make sure folks, when you have your questions, feel free to ask them. I don't want to shut down any discussions. Item number 1 is the approval of the minutes. Included in your packets are copies of the minutes from our January 20, 2023 Commissioner Educational Retreat meeting that took place in person and by video. And we'll start with that. Is there a motion to approve the minutes of the January 20, 2023?
So moved.
Great. Is there any discussion? I'm sorry, should I get a second? Can I get a second? Thank you, Commissioner Wood, a second. Anybody have any questions or discussion? All right, all in favor of approving the minutes? Say aye.
Aye.
Any opposed? It's passed. The second one are the minutes from the March 16, 2023 public meeting that took place in person and by video conference. And can I get a motion to approve those minutes?
Motion to approve.
Commissioner Wood has moved. Can I get a second? Second. Any discussion or questions? All right, all in favor of approving those minutes, say aye. Aye. Are there any opposed? Okay, agenda item number 2.
My goodness, not many of us are on there, no, Valerie?
Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Go ahead, Commissioner Boyle.
On page 8, the data patient satisfaction across Maryland hospitals has remained historically lower than national averages. I guess it says staff has begun preliminary analysis to identify potential differences. Is there any been any comment on any progress we're making and why we should be so much lower?
It's a persistent trend in terms of performance on CAHPS and other quality metrics. I think that's an ongoing point of debate with the with CMS on why Maryland does so poorly. A couple things are really pretty obvious. Wait times in EDs have historically been excessive in Maryland. There's been a variety of efforts to try to mitigate that with far from complete success. There was a piece of legislation that was introduced to again look at wait times, and it didn't pass, but the governor's office signaled that they want to go forward and try to uncover that particular metric a little bit further. But the quality performance of Maryland hospitals is a drag on the overall model. We have improved somewhat, but there's a lot of more progress that needs to be made. This consumer satisfaction questions, it's probably fair to note that consumer satisfaction as measured by the Family Satisfaction Survey, et cetera, is also not as strong in terms of the NCQA measures on health plans. Maryland health plans do okay, but they're not necessarily leading the nation either. And I have one observation is it perhaps quality issues, which I think that would be what you would start with. But our consumers also more skeptical on the East Coast. That may be a function of low satisfaction scores across the entire swath of healthcare providers. And just get the consumers just rate our healthcare providers, payers, et cetera, less favorably than say they do in the Midwest. You've heard the term Midwest nice. I think there is something to be said to how consumers unnecessarily might look at and assess performance that differs across the country, but that doesn't really alleviate the fact that there's some success that we can still achieve. I think the issues on some of the ED wait times, especially, are function of culture and what may not be necessarily accepted in a hospital in North Carolina, kind of because it's been such a historic trend here, the industry has been more willing to accept it than in some other places. That's my opinion, not necessarily weighted by the evidence, but it certainly is something that total cost of care model that we're riveted on trying to improve.
Is there any thought that the funding model has impact on this, in that it's not necessarily a competitive marketplace for hospital providers, whereas they have relatively fixed incomes, and whereas in other states there's a bit of a competitive nature, driving through other states, seeing the billboards advertising wait times in ERs.
Well, I will, I mean, I think one of the ideas on the billboards on the wait times, and if you've gone up 95 or going down 95 as you hit Fredericksburg, Virginia, you'll see the wait times. There have been, that's a great idea, but I've seen studies that show those wait times are not necessarily what individual patients experience.
I see that more as a reflection of the competitive nature between the hospitals when they're more fee for service funded, and they work hard to draw patients to their facility over others, rather than sort of top down total budget funding.
Yeah, I mean, I don't know how much of I think the health systems are competitive in that regard, but in terms of wait times, everyone does pretty poorly. The state, there are some of the rural hospitals seem to be.
When this is Dr. Bhandari, I have a question. Do we know what is the wait? What does they are considering the wait time? Is it somebody in the ER, a receptionist, or somebody comes and get the information? That's where the clock starts, because there is a difference between anyone non-medical talking to the patient, if that's the less wait time, there is a lot of flaw about that, because many hospitals, they talk to the patient, but not seen by the doctor or provider for many, many hours. They say, well, our wait time is much shorter because somebody came in and talk to you and register the patient.
So the wait time that we now are measured on, there used to be about a half or 4 metrics. There are only 2 currently and one is time from arrival in the ED to admission. And the second one is left without being. There was another metric, time in the ED until discharge from to home. That is, it was a visit that didn't lead to an admission. CMS has dropped that. I think there's some talk about resurrecting some of those measures. But right now, there are only 2 ED measures that Maryland and hospitals across the country are benchmarked against. There is a movement afoot to add what's called an electronic ECQM quality metric, which would add one of the wait time measures back in. But what Commissioner Boyle really raised is across the board, I think our quality metrics have some room for improvement. But I'm somewhat riveted on ED wait time because that touches on some of the things we do with trauma as well.
I had a question on the project management consulting services entry. Can you tell me a little bit about the plan for the new RFP? What do we envision using the PMO for? It looked like a very big round bag of different things. What are we looking for, and how long are we trying to contract with? How do we envision?
So the philosophy on contracting has been to try to move these out to 5 years or more. Just generally, that's most of our long-term contracts are for 5 years, mostly because we think there's value and continuity into the RFP process. It's complicated in the state, so it makes sense to sort of capture the input cost of doing an RFP across a longer duration. So I think the plan is for 5 or 6 years on this particular RFP. It started out, the PMO work was in support of the development of the APCD, the evolution of the APCD awarded in 2014 or 2015. That support has continued, and we are expanding it now to include the support for the gathering of non-claim information that the legislature directed us to evaluate in the legislation passed last year. So we've added that in. We've also are using this vendor through a small contract to assist in management of the primary care work group that is an ongoing responsibility of the commission. And we believe this PMO procurement would be a vehicle through which we could get some support for developing the primary care work group. The current contractor, and it will be an open and competitive procurement, but the current contractor has a couple nationally known experts that have developed the primary care investment models in other states. One they're working directly with Delaware now, but there are other competitors that may also bid. So you're kind of right that we are expanding this. We've seen good value in having assist us with these various activities. They are generally consistent with the concept of a project management office. And I think we found it gives us good value in not only monitoring what's going on, but being a fountain for new ideas that are being tried elsewhere. So we look forward to a competitive procurement. There's a fair number of entities in this workspace, and provide some addition, some support. Major projects that Ken and his team are embarked on. I'll leave it at that. And if you want, I think I pretty much covered it.
Thank you. Welcome, Commissioner Jensen. And was there anybody else that had a question on the update of activities? That, do you have any additional updates?
A brief update today. First off, I want to congratulate Winnie Hawk. She has been appointed new Center Director for Healthcare Facilities Planning and Development. We had a very competitive recruitment effort. This position, when you go out and hire for it, it's kind of like trying to find the athlete, because the scope of healthcare facility planning is very broad, and you have to identify someone who can do a lot of things well. And among the various candidates that we had, the review panel recommended Winnie. Chair Sargent and I interviewed the final two applicants, and we too concluded that Winnie would best meet the overall needs of the commission. And I'm very pleased she accepted the job. I look forward to working with her, and I'm sure she'll do a great service to the state. Secondly, I want to introduce Ali McStudy, who's joining us from the Henry Jackson Foundation for Military Healthcare in Bethesda. She has about, I think, 8 years of service with the U.S. Navy behind her. She has a Master's of Public Health from GW and an undergraduate degree from Seton Hall. So we think that the perspective that she brings to the commission will be valuable, and wish you the very best. Welcome.
Welcome.
The last couple notes, I just want to recognize all the work that staff did over the legislative session, in particular, Tracy DeShields, Dee Stevens, and Richard Proctor were our legislative team, relying on the centers for additional information, and our assistant AGs for guidance on particular bills impact on our statute, or potential broader impact on sister organizations within the Department of Health. So I want to recognize all those people for the work they did. It's been a fairly busy and unexpectedly additional work has been added to our agenda. You're going to hear more about that later on, but it was a pretty, I think the governor thought it was successful. And so do I. Successful session. So look forward to the new assignments moving forward. One of the areas that we are working with our sister organization in the department is on the progression plan. The state has to develop a progression plan for what's going to happen after 2026. I think I mentioned there have been some small, largely internal work groups focusing on cost containment, financial targets, population health, and health equity, consumer engagement, multi-payer alignment, healthcare practitioner engagement, post-acute and long-term care engagement. We are taking the lead on the post-acute care alignment work group. Paul, while he was here, played a major role in that, and Winnie and I and others are going to pick that up to make sure there's a report back to HSCRC. I had mentioned at one point that this was going to be more broadly inclusive, and Chair Sargent had suggested that we add commissioners to these work groups, but it turned out that the HSCRC wanted to maybe more narrowly configure these work groups, and there didn't seem to be an opportunity to add commissioners. They tended to be largely composed of either state staff or stakeholders. In the case of payers, for example, Care First, Medicaid, et cetera. In the case of physicians, MedCai and representatives from the physician community, et cetera. So I know I'd promised to engage commissioners, but I'm also mindful of not wasting time. And it didn't seem like there are opportunities to really participate in a meaningful way. And, I will be continuing to look for opportunities. But it's not, I don't want to just ask commissioners to attend for the sake of attendance. It didn't seem like these are going to be the ways in which we can effectively wouldn't just stay tuned. The progression plan is going to be moving forward over the summer, and there'll be opportunities to get a better picture of what the state's proposing to do. That's all I have.
Thank you, Ben. Thank you for continuing to look for opportunities. I agree with you that we don't want to waste the commissioner's time, but it's good for us as commissioners to get involved in something other than just the meeting. So we see a bigger piece of the picture collectively. Are there any questions for the executive director? Great. Before we move on to action items, I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform the chair and state their recusal on the record when the item is announced. For commissioners participating remotely who desire to recuse, they should remain silent, turn off their cameras, and mute their phones. Commissioners here in room 100 who are recused should move to the small conference room. That we can turn to agenda item number 3. Publication of proposed regulations, COMAR 1024-01. The next agenda item is a presentation of proposed changes to the procedural regulations for healthcare facilities and services, COMAR 1024-01, which govern the commission's certificate of need CON program. The proposed changes stem from the MHCC CON Modernization Task Force, Governor Hogan's Regulatory Reform Commission, and the significant changes to the commission's enabling statute since COMAR 1024-01 was last modified in 2005. Generally, the proposal streamlines CON reviews, creates new review criteria to support the commission's strategic objectives, and clarifies regulatory oversight of non-CON projects. The commission will need to approve the proposal for formal publication. Presenting will be Caitlin Tepe, Assistant Attorney General, and Winnie Hawk, Chief CON. Caitlin.
Yes, thank you, Mr. Chairman and members of the commission. I am here today. Caitlin and I are here to present. We're going to try to provide an overview, a high-level overview of COMAR 1024-01, which are affectionately known as the procedural regs governing the Certificate of Need program. So the regulatory process requires commission approval before these regulations are posted formally for public comment. And that's what we're here to do today. In terms of the agenda, we're going to discuss, next slide, please. Next slide. Okay, in terms of the agenda, we're going to discuss the background, the timeline, and highlight the changes. In terms of the next slide, please. In terms of the background, the update of these regs stem from 2 major reform efforts, as well as 18 years of statutory changes. In terms of the first reform commission, in 2015, the Governor Hogan had a regulatory reform commission, and it was established by executive order, and that was to examine and make recommendations on streamlining Maryland's regulatory environment. As a result of the work of that commission, the commission called for modernization of 4 state health plan chapters: home health, nursing homes, drug abuse, intermediate care facilities, and of course the CON procedural regulations. Next slide, please. Oh, I'm sorry, I keep forgetting to say next slide.
Next slide.
The next slide. The second reform, huge big reform effort, was the Maryland Healthcare Commission CON Modernization Task Force. That was in 2018. And that task force identified a number of certificate of need streamlining objectives. Many recommendations required statutory changes. Some recommendations called for that could be implemented through changes to the regulations. And since 2018, since this task force, the 2018 task force, a strategic priority has been to to conduct a comprehensive overhaul of the procedural regulations. Next slide, please. So this was the last 18 years have passed since this 18 years of statutory changes have occurred in the 18 years since the regs have been updated. They have not been updated since 2005. There were statutory changes in 2012 related to cardiac services. In 2015, the FMF conversions. 2019, there were several changes related to capital expenditures, increasing the threshold for ambulatory surgical facilities from 2 to 3 operating rooms, as well as deemed approval for uncontested projects. All of these statutory changes essentially are a precursor for reform of these procedural regulations. Next slide, please. Now I'm going to turn it over to Caitlin, and she's going to walk you through the timeline and highlight the specific changes.
Good afternoon. So I'm just going to briefly describe where we have gone, what we've done, and where we still need to go. So the staff drafted the regulations between 2021 and 2023. We published them for informal comment last summer, July 2022. We received about 13 submissions, which amounted to about hundreds of pages of worth of comments. They were very voluminous, a lot of stakeholder interest. We spent many months reviewing those, probably dozens of meetings among staff, reviewing every single comment that was received. We decided that we were going to re-release the regulations for a second round of informal comment based on how much feedback we received. And we held a webinar in February 2023 before re-releasing the procedural regulations, just to kind of highlight why we changed some of the things we did based on the stakeholder feedback and why we didn't change. So Paul Parker led that webinar, and it was well attended, to kind of explain the commission's position on some of the changes and then some of the areas where they chose not to change. Then we re-released the regulations for another round of informal comment, received 5 submissions. And what is in front of you today is the product of that. So today we ask for your review and approval of these regulations to formally post for formal comment. And I kind of minimized what that really looks like. There's a lot of steps between here and there. We have to submit it to the governor, to the ALER for review, but once it gets submitted, there'll be another open comment period for formal comments. We will review those formal comments, and then we will come back to you for final action for these regulations. Next slide, please. Next slide, please. So I'm going to just highlight some of the changes that we made. I know Ben had submitted the red line version, and all of these documents are online, and we've been posting them online as it's been happening simultaneously, so the public could kind of follow along with us as we proceed forward. And so you can see through your document, the red line version, that there were a lot of changes. So I'm just going to highlight the ones that seem to be the most interest to the commission and also to the stakeholders that kind of received the most comments about. So the first kind of priority was streamlining the CON review. One of the complaints that's routinely made about the CON program is the length of time that it takes for a commission to make a decision. So while the commission's enabling statute imposes deadlines for making decisions on applications after it's docketed, there are no deadlines before it's docketed. And that's really where this completeness review is taking place. And that's where there's significant delay in the review of an application. So the proposed regulations address this concern by imposing stricter limits on the completeness review. Now, the proposed regulations make staff complete the review with just basically one round of completeness review, meaning you can only ask for questions one time. And then if there's good cause, you can ask one more time. So for all the commissioners that have been involved in reviews, you know that sometimes these rounds of completeness can go on for quite some time. So now we've limited. Staff need to compile all of their questions with one robust round, and hopefully that will address a lot of the issues. Because we're limiting how many times staff can ask questions, we've extended the amount of time in which staff is able to respond. So staff has to respond 20 business days for projects involving the establishment of a healthcare facility, relocation of a healthcare facility, or the introduction of hospital cardiac surgery or organ transplant. Otherwise, 15 business days for all other projects. And just to kind of put this in perspective, right now it's 10 calendar days. That's quite a fast turnaround for staff. So we're increasing the amount of time for them to respond, but limiting the amount of times that they can ask. Next slide, please. Also, in an effort to streamline the review, we have limited who qualifies as an interested party. And really, we changed the definition of adversely affected. So the previous definition of an interested party, and as a reminder, an interested party is a very valuable role that provides an important perspective in evaluating applications, but they also have significant rights once recognized as an interested party. They have the right to file an appeal of a commission decision, and their inclusion in the CON review can really prolong the review. So this was an important definition to review. So the previous definition of an interested party was someone who could demonstrate that they were adversely affected, which meant authorized to provide the same service as the applicant in the same plan and region. And that was it. So now, in order to qualify as an interested party, again, you have to be someone who's authorized to provide the same service. This is one portion of an interested party. There are other ways that you can qualify, but the same service as the applicant in the same planning region, but also who can demonstrate that the approval of the project would either materially affect the quality of care at the healthcare facility that that person operates, such as causing a reduction in the volume of services when volume is linked to maintaining quality of care, or two, would result in a substantial depletion of essential personnel or resources from that healthcare facility. And we think that the staff thought that this really struck the right balance of making sure that the interested parties that are being recognized, are very being affected by the proposed project. Next slide, please. Okay, and there are two additional review criteria. The first is health equity. So the commission, which is defined there, that you can all read. And the second one is character and competence, which assesses the character and competence of an applicant, which we really already do. We already ask a lot of these questions in the application, but this kind of formalizes the way to review that information. And so we want to make sure that if someone's entering the Maryland market, we're going to review how they performed previously. So we're going to look at violations in operating other healthcare facilities they've had. Next slide. Oh, no, that's good. Okay. So the next area is regulation of non-CON projects. So I'm sure as the commission has noticed, they review projects that don't fall under the full CON process, but are other types of reviews that are permitted under the statute. So we're talking about exemptions and determinations of coverage. And an example of an exemption would be a conversion of a hospital into a freestanding medical facility or a consolidation of healthcare facilities. And these projects are starting to increase more. So the current regulations provide guidance on how to conduct these reviews, but they don't explicitly address how the commission should monitor the exemption projects post-approval through implementation. So historically, the commission has interpreted the regulations as governing CON projects post-approval as applying to projects that have been approved through the exemption. So previously, the commission has applied those same post-approval kind of obligations for these exemption projects. And so this rule just kind of formalizes what they've done in practice. So the proposed regulations would explicitly incorporate the commission's longstanding application of these regulations. And this is through creating a definition of holder. So if you are a holder, you are someone that have received commission approval for various projects, both through the CON process, but also through this exemption process, which is a faster, way to approval. So the benefits of this is that an exemption holder can seek approval for certain project changes through a truncated project change process rather than seeking a new exemption. And we can also approve exemption requests with conditions, which is really a benefit to an applicant because a lot of times it's a very worthwhile project, but they don't necessarily meet the required standards. And so we're able to approve the project with conditions that they promise to do something in the future that would kind of put them more in compliance. Okay, next slide. Another way that we address regulation of non-CON projects is kind of making sure that staff timely respond to requests. So in the new regulation, the commission shall issue an exemption within 45 days after it receives the notice of intent. And if it doesn't, there can be a deemed approval after 90 days. And so this also kind of addresses some of the stakeholders' feedback about wanting to have faster action on these requests. And so this really forces staff to timely respond to these requests. And if they don't, and they're within those 90 days, and it's a project that would be eligible for this determination, then it's deemed approved.
Can I ask a question now or at the end? It's totally up to you. Up to you.
Go ahead.
Okay, thank you. Can you give an example on the third bullet that I guess first, do we have sufficient staff for these periods of time? So what kind of project could then be deemed approved if because of staffing or whatever, we didn't have the time to address it appropriately?
So I will also say that if the period in which the clock starts is when they have a complete request. And so if it's incomplete and we've asked for more information, so it's, you know, it's kind of like when it started docketing. It's a kind of parallel between CON projects. And so it's not necessarily 45 days, it's kind of until they have a complete request. And so the first one is 45, and so the deemed eligibility timeline is 90 days. That's double the time that staff is really supposed to respond. I don't know if Winnie or Ben wants to talk about staffing, but I think consensus was that this could be done with our staff.
I have confidence in my staff to meet these deadlines. And I think that having deadlines is and the new regulations is going to be very helpful. So I really don't have any worries. It shouldn't take as long as some of them have.
And one of the advantages of having a new center director is the opportunity to look at the configuration of the entire center. It's noteworthy that it's the biggest, nearly double the size of the next largest center. We are compartmentalized in health planning into three divisions. Acute care planning and specialized services headed up by Eileen Fleck. Long-term care planning, which is led by Linda Cole, and then the CON program direction, which was until Winnie was appointed center director. She was the division chief there. I think there are opportunities for using the staff more effectively across the entire organization, but especially in the Center for Healthcare Planning, where moving some assignments around might actually be very welcome by staff because they get to do a broader swath of activities. You know, as I said, it's we want decathletes in this center. They have to be good at a number of different things, and Winnie and I both think some refreshing would be valuable. So, long answer to your short question. Yes, I think we have the staff. We are obviously just beginning a search for a new CON director. And we'll also be looking for a senior person that can head up our financial and planning assessment group as well. So we have two high-level positions we want to fill in short order.
I would also mention that we added a provision where if the staff does not make a decision within 45 days, they have to come to the very next commission meeting and provide a status update. And that status update has to continue for every subsequent commission meeting in which a decision was made. So the commission should be aware that this, is happening and that wasn't made within those 45 days.
Thank you. I was curious where the commission.
The deemed approval requirement that doesn't apply to CON stuff, you would sort of, what would be deemed would be, we've deemed that you do not need a CON for the thing that you have applied for. Is that right? It's like we aren't granting CONs through deemed approval.
No,
We're
these are
determining you're not within the scope of CON.
correct. These are for non-CON
Exemptions.
terminations.
I'm not sure we could grant a CON, but you probably have to act.
There is deemed approval language, CON projects, but for the purposes of this slide, we're talking about not exemptions and determinations of coverage.
Okay.
And any other non-CON.
So yeah, legislation passed in 2019 did include a deemed approval
Yeah, you're right.
provision that
Right.
that we are loath to use, and deemed approval. If we came up to that, I think we would come up with a tough decision on whether, we oftentimes the reason deadlines approach is sometimes they're tough decisions. And we're trying to get more information from an applicant. And with deemed approval, I think the bias might be to send an application back with a it's not complete. You have to refile. So we've never been in that situation, but we are aware of that requirement.
Next slide, please. Right, the next area was increased flexibility post-approval. So the current regulations have strict deadlines about implementing approved projects, which does not provide flexibility for the needs of different scales of projects. Applicants routinely ask for extensions for these, and so the commission has decided to allow the applicants more flexibility by allowing them to propose their own schedules. So under 1024-0112, they propose the schedule for implementation for their own projects, and then they are obligated to try to stick by the schedule that they proposed. Next slide, please. We did also amend the emergency CON provision. The current regulations did not anticipate something like a pandemic, like the COVID-19 crisis. And so the amendments, one of them was that the emergency CON shall be extended automatically during the period in which an applicant sought a CON to retain the capacity or the project approved. We thought this was very important to make sure that there was no disruption. Oh, can you go back one? No disruption in the services while the commission was reviewing a permanent CON. And then the other one permits us an emergency CON applicant to seek reconsideration by the commission if the executive director denies it. And we thought that that was important to preserve the procedural rights of the applicants. Slide, please.
Does it require that there be the ongoing emergency? That automatic renewal?
To an ongoing emergency to apply for the permanent CON?
For the automatic renewal, say if the emergency is not extended, like we just saw the end of the federal COVID emergency, right? Does our automatic renewal take into account whether or not the state of emergency is ongoing? But to get that.
Well,
So we allowed ourselves, flexibility. I'll let Caitlin respond specifically, but recall that the emergency CON authority did not contemplate a pandemic. It contemplated a facility flooding, potentially not fire, some disaster specific to that facility. Didn't anticipate that. We think that it broadened. We have the authority. We want to preserve that authority, but a public health emergency. I'll let the staff respond, but it's not the only framework through which an emergency ceiling could be issued. We don't need a determination of by the federal government or by the state that this is a public health emergency in order to apply this emergency CON authority. Is that correct, Caitlin?
I wasn't listening to you, so I was trying
Okay.
to find this, but to answer your.
That's, I think my question was,
No. We don't need it.
No, or at
We don't
least
need a public-
it's silent.
it's
in
not
the-
tied to a
Public
public health
health
emergency, okay,
Sure.
because there are more localized emergencies. That makes sense. I mean, I'd say probably the commission should, if there are extensions, should get reports on what they are, especially if there's not a public health emergency. We know. But I assume that would be easy to do anyway.
And off topic, but the emergency CONs that have been issued expire on April 30th of this year. A number of entities have come forward with plans to continue operations. A number of instruments that are available to the either a CON or a determination of non-coverage. So. either of that.
And then the last topic that I had planned to discuss, oh, can you go back one, please? It was the introduction of a consent agenda, which would allow the commission to act on certain items through the use of the consent agenda, which other agencies and commissions use throughout the state. And so there are a limit on what could be on a consent agenda, but things like an approval of a project change that doesn't change the financing mechanism, a confirmation of an emergency CON issued by the executive director, or other items that the commissioners vote to include on the consent agenda. And so kind of what that would look like is that the commissioners would receive this agenda prior to the meeting. And if on the day of the meeting, the commissioner wanted to remove it off the consent agenda and wanted to discuss it, that could happen, and we could put it on the agenda for that day, or it could be moved until next month's meeting. So there's a lot of flexibility in how this commission wants to use it.
Yeah, I suggest we include minutes on the consent agenda. If that takes a vote by the commission, so we don't have to have special motions for the minutes every week. But the commission, we use consent agendas on our boards. They are great for administrative things. If anybody has an issue with anything on the agenda, you just say, I would like to discuss item 5, comes right off the agenda. We will have a discussion of the item and other items that things like minutes, administrative noise and comments about, we can move out and focus on the things that we want.
Oh, thank you for that explanation.
Next slide. Concludes our presentation. Happy to answer any other questions.
Thank you. So really new to this commission, what's our role here in this process? To receive a report and say good job and move on, or is this to solicit input from us, or us to vote to approve them as written? I'm just kind of give me some perspective as to what really is our purpose in discussing it here this afternoon.
Can I answer that, Ben?
Go ahead.
Well, I can answer it. We were asking you to vote to approve them to be posted for public comment. So this is essentially a step, it's a formal process. Doesn't mean that it's the end. Anybody that is submitted, you get, so what happens now is the comments submitted, up until now, it's all been informal.
Mm.
And the comments submitted will become part of a public record. And we are required to respond to those comments and document that, either we accepted the suggestion, if it's a suggested change, or we reject it. And if it's a substantive change, we bring it back to the commission. And
So, yeah, at this point, we can continue to edit them. So if the commissioners had any feedback or wanted to discuss anything or had any concerns, this would be an opportunity.
But it's simply to put it out there formally, officially for the public.
I guess you all are doing this work on our behalf as our representatives, so therefore we're attesting that this work meets our. We stand behind it and give it our consent, so it comes from us rather than just someone else.
Oh,
These are state, these are, will eventually be state regulations.
Yeah.
So it'll be basically, these are important regulations for the operation of the health planning and CON function. I can attest to, it's about 80 pages of procedure, and we've given the interested parties opportunities to informally comment. Just a note on that, that provides us for opportunities to get feedback quickly, change the regs without formally promulgating them. We hope we've eliminated most of the issues through that process, so that when we go forward with the formal process, there will be less issues that would require, coming back to the commission and saying, this party thinks that particular regulation needs to be changed. Because that, at this stage, after, should you vote today and approve, it will require bringing them back for you again. The informal process is by definition more informal. We get what we hope are the most significant objections out of the way ahead of time.
I will mention also that if the next time we bring these regulations in front of you, you want to make substantive changes, it has to get re-released. So this is the opportunity to please mention.
We start a cycle now. If we publish it, get comments. If we change it, we have to publish it and get comments. If we change it, so that the
Correct.
public has a chance to weigh in on all the changes that we
Mr. Chair, I'd like
make.
to,
Commissioner O'Grady?
yes, I'd like to speak in support of this. I think especially they've given a lot of thought to this idea, how many rounds to go with the people, the applicants and the other interested parties and whatnot, which the three of us have shared together on a number of reviews here, where it seems to be kind of an endless going around, and you'll ask for things and they'll give you 2/3 of them. And it's not bad faith. They know there'll be another round. And so I guess I like that very much, the way you laid it out, that there's got to be sort of a reasonable turnaround. And it's pretty much, we're going to cut it off after a certain time. I do think the commission gets kind of a bad rep that to a certain degree, we're not getting responses to the full list of questions we're asking, because they know there'll always be more time. And therefore, but the commission gets blamed for this dragging on. And so this idea of, we've got 1 or 2 rounds. And if you don't answer our questions, if you don't make a serious response, that's what you'll be judged on. So it's a little hard medicine, back to some of the people who'd like to do things. But it is, I think, an excellent option of saying, no, we don't want these reviews to go on month after month, year after year. You've got to bring it to a close. And I'm sorry if that puts people under time. I think they've adjusted for that and giving the staff a little more time. I would not be surprised if one of your first public comments is the applicants and the interested party asking for a little. There's only going to be 2 rounds at most. They may ask for a little more time as well, because some of those responses, they did look like they just didn't quite get through the list of questions we had for them. And they didn't worry about it because they'd have another shot at it in the next round. So I think that's a great option. Certainly meets a lot of the frustrations that I had in doing reviews. And I just wanted to support it.
Well, Commissioner, I have a question for you, Commissioner O'Grady, then. Do I have a motion to approve the publication for formal comment?
You Yes, you do. Happy
And a
to.
second? And a second? Anyone?
I'll say,
Second for Commissioner Boyle. Great. Now we'll have discussion items. Commissioner Jensen, did you have a comment or a question? Just wanted to move us to the
got it.
official discussion phase.
2 questions. I am not, this is just curiosity. I'm not leaning this way at all, but if we did not approve these, could they become official regulations anyway? I mean, is our approval required?
Yes.
Okay, number one. Number two, can you give us a flavor of the who provided comments and what the 13 I don't obviously need a summary of hundreds of pages, but if there's 13 comments, who submitted them and roughly what were they?
Here they are. So there's a lot of them. They're on our website. So I think, you know, what we've highlighted today was
Okay.
mostly what the stakeholders, I mean, so what we did is we identified every single comment that came in for every single person. And so there are certain sections that, 10 people talked about this, you know, we really need to relook at this. And we made changes. I mean, you can look at the two drafters, we took stakeholders and, you know, comments and we considered them and we made changes based on, you know, this is not workable or this is, you know, whatever the feedback was. I can tell you, do you want me to tell you who submitted?
I'm just trying to get a flavor of who it was. I mean,
Are there categories like
Hospital systems
or attorneys?
So
yeah, I mean, thank you.
Why don't you list who commented? And then
So-
highlight all the areas. I think that. I think
So, the law firm, Gallagher, Ellis and Jones, submitted 66 pages of comments. Hospice and Palliative Care Network, Maryland National Capital Home Care Association, Baker Donaldson, the law firm, Maryland Hospital Association, the Office of the Attorney General Consumer Protection Division. Said, Holy Cross Health. Title Health. Lifespan Network.
Nothing from Hopkins or MedStar?
That's in the hospital association though. Part of-
And some of the law firms, I think, represent multiple entities. I mean,
Right, it just. It almost said that.
they were also, and like we said, they were simultaneously posted, and so other people could see what the comments were and if they felt like maybe their concerns were covered.
I appreciate the engagement. That the commenter showed. It's not fun to read and comment on procedural regulations, but it's a really hard job to develop a fair procedure that is still efficient and you know, doesn't come to arbitrary results. So done a real service to the commission by the effort put into the giant stack of comments.
Agreed.
Are there any other commissioners with questions or comments? I have one on the health equity and the new health equity criteria. And it's based on just with government agencies in general. I've seen that they often when they have to make a decision, they have an easier time with 5 black and white yes, no questions than they might have with one open-ended question where they don't quite know how to write an answer that can't be challenged to it. And health equity is such a broad area. What are we going to do with that in the sense of so that we can quickly come to a determination on a matter and satisfy that criteria instead of avoiding, I want to avoid going down a rabbit hole of analyzing it because it's a complicated area. You can always analyze it. Like, how do we cabin that so that we keep the process efficient at the same time in a new area?
What criteria, is it the criteria that we're going to consider, or I think
It's kind of that and bringing ourselves to a conclusion, right? Because health equity is one of those areas where you're going to have differing minds that differ, and it will require the agency to take a position that can be challenged almost whichever. So how do we make sure that we get to our position, stick to it, we collectively, meaning like say the staff gets to the position, sticks to it, even though it can be challenged and brings it forward and we go to the next step.
I think it's actually, we've been discussing it internally and our discussions will be ongoing as these regulations move through the promulgation process, because I think we are trying to evaluate the best way to do that. But I do think that every project is going to have they're going to have different measurements.
Yes.
based on the type of facility or the location. There are different factors, but, and honestly, to an extent, we currently consider some of these factors already when we look at charitable care, when we look at geographic distribution. So I think it is something that we are gonna seriously evaluate and come together with an internal group to figure out how to do this in a fair and equitable way. But I think what's gonna be squishy about it is it's gonna be different depending on the project. I don't know, do you have something to add to that, Caitlin or Ben?
So. I think the observation that some of the precursors to health equity were in some of the considerations we looked at. Historically, particularly charity care and reasonable access, which is trickled through a lot of our health planning chapters. I think, where we'll have to wrestle with is, how do we factor in kind of the new flavor for healthcare equity, which it looks at underlying deprivation, which is just taking root in Maryland. As some of you've heard Melanie and David talk about and the MDPCP, there are adjustments for patients in these models that live in areas of this that have higher deprivation indexes, and consequently more funding is made available to the practices that serve those patients. In particular, if the patient is also has a higher degree of acuity, sickness acuity as measured by a metric that CMS has developed called the hierarchical categorization, which codes HCC scores. So we're gonna have to figure out how we pull these things together and use them. It's one thing when you're talking about individual patients. It's another, I think, more challenging issue when you're looking at broader geographic areas, because the populations are much more diffuse, and how do you really target it? Expanded service to a population that's in need, but in fact, the jurisdiction may be high income, high SES status overall. So I think we're gonna have to think hard about how we work on this. Certainly, there is across state government broadly, everyone's thinking about this. So I think we're gonna be learning from each other as we go forward and how to articulate this. Certainly, and I've heard this last couple of years, there's great concern about the health system in Prince George's County, notwithstanding very significant expansions that have occurred there in the last 5 or 6 years, with the establishment of a new hospital by AMS, the acquisition of Doctors Community, the acquisition of the Fort Washington Hospital by Adventist Health, and the anticipated replacement of that facility. But it's not just simply facilities that matter. I think more important is ability to attract healthcare providers, which people went out. If you don't have the facilities, you're not going to attract the providers, which are as well. So, we have some work to do in this area. But I think it's exciting and important work.
And to follow up just on my question is, I think what's here in regulations is good, but we should just be thinking as we're implementing, it's a new area. How do we look for the two things in a new area that concern me in general? It's not about equity, it's about the new areas. Consistency and not having analysis paralysis stop us from, moving the CONs and the other things forward in the time that we had to. So we'll still need to get to a position, even if it's hard. And we'll need to find a way to say that position is something we would be consistent with as other cases arise. But I don't think I would write that into the regulations now, because I wouldn't. Right.
Duly noted.
Are there any other questions or comments before I call a vote? All in favor of publishing the draft regulations? Say
Aye.
Aye.
Are there any opposed? Motion carries. Thank you, and thank you for the very hard work. This was quite a task, and I'm glad to see it moving forward.
Nice job.
On to agenda item number 4. The next item on the agenda is a certificate of need application filed by Chesapeake Eye Surgery Center for the addition of 1 sterile OR to its existing 2 OR ambulatory surgery centers. The project will result in a total of 3 sterile ORs after project completion, thereby establish an ambulatory surgical facility in Anne Arundel County, Maryland. Program manager and CON analyst Laura Herod-Nerschel will be presenting the staff recommendation. Welcome, Laura.
Good afternoon, Chairman and Commissioners. Thank you very much for that introduction. Chesapeake Eye Surgery Center is an existing ambulatory surgery center that provides ophthalmic surgery, and outpatient procedures with 2 operating rooms and 2 procedure rooms located in Annapolis, Anne Arundel County. Chesapeake Eye is requesting a CON to renovate its existing center to add 1 sterile OR, resulting in 3 sterile ORs after project completion, and thereby establishing an ambulatory surgical facility at an estimated cost of approximately $636,000 paid for in cash by the applicant. Need for the project is based on recent increases in case volume, which have directed the facility to hire 2 new surgeons to address that additional volume and to grow the volume further. The projected surgical volume, case volume, and OR surgical minutes support the need for the addition of the 3rd operating room and the establishment of the ASF. Regarding viability, staff concludes that Chesapeake Eye's case volume and financial forecasts are credible. The applicant will pay for the project with cash that it has on hand, and the applicant's revenue and expense statements estimate that the project will make a profit for the facility by the end of the 1st year after completion. Therefore, the project is financially viable and is a cost-effective option for delivering outpatient ophthalmological surgical services to residents within its service area. As for impact, the project will not have a negative impact on patient access and will not have a negative impact on the cost of outpatient surgery in the service area. Also, the project will not have a negative impact on existing providers of surgical services because these types of ophthalmological procedures are already being performed in outpatient settings. In summary, the proposed project complies with the applicable standards in the General Surgical Services chapter of the State Health Plan, has demonstrated need, is the most cost-effective approach, is viable, and will not have an impact on the cost of outpatient surgical services in Maryland. Therefore, staff recommends that the commission approve this project with the following condition, and this condition is standard for all ambulatory surgical facilities seeking a CON, and that is Chesapeake Eye Surgery Center shall continue to provide a patient with an estimate of out-of-pocket charges prior to arrival for surgery. Representatives from Chesapeake Eye Surgery Center are attending, I'm told, by virtually today. Those are Jennifer Knopp, Director of Surgical Services for the facility, Scott Lestova, Senior Financial Analyst, and Thomas Patillo, VP of Facilities and Resource Management. Happy to answer any questions you may have.
Great. Why don't we start with the motion and then we'll have discussion. Do I have a motion to approve the certificate of need, Chesapeake Eye Surgery Center LLC, establish an ambulatory surgical facility?
We'll move.
Commissioner Johnson has made the motion. Is there a second? Commissioner Boyle? Thank you. Great. Are there any commissioners that have comments or questions?
This is Commissioner Bhandari. Do we know why the volume has gone up? Because is there any particular reason or acquisition by the 3rd party?
So during the pandemic, all outpatient procedures that were elective were put on hold, obviously. So people were putting on hold their cataract surgeries, their or LASIK surgeries, et cetera. So there has been an influx due to that, but also we have an aging population in Maryland. The plus 65 plus population is growing every year. And especially in that region in Anne Arundel County, it's a lovely place to retire. So they seem to have supported their need through saying that the increases are from that aging population, which will require eye surgeries.
I think COVID backlog should be, should not be there anymore. It has been a long time. Can we hear from Chesapeake Eye Surgery Center? What's their opinion? What is their side? Why there is increase in the volume?
Jennifer, if you would like to answer that.
Yes, good afternoon, Dr. Bhandari. It is true that our population is growing. We have passed a lot of the pandemic patients. We have gotten those patients done and completed with surgery, but our population is growing, so the volume is increasing. We've also added additional surgeons to our facility because of the need, so.
What surgeries are they going to do? Cataract, what other ones?
Cataract, ocular plastics, glaucoma, retina.
Thank you.
Mhm.
Great. Are there any other questions or comments?
Is there enough space in that building?
Yes, there
Enough parking?
Yes, we're in a hospital facility in the Sajak Pavilion, and there is a large amount of parking in that facility, in that location.
I practice in your neighborhood. I know exactly what the area is. Parking is a problem.
Fortunately, that's not part of the CON
I know.
analysis.
Trust me, especially after eye surgery. Yeah.
I haven't had that issue on my surveys, so it hasn't been an issue at our facility yet, but that doesn't mean it won't be.
Thank you.
You're welcome.
Great. Are there any other questions or comments? Great. All in favor of the motion?
Aye.
Aye. Are there any commissioners who are opposed? I think you have your CON. Congratulations.
Thank you very much.
Thank you.
Really, the eyes have it.
Thank you.
Ayes have it. Use that commission. Agenda item number 5. The second request for a post-approval project change for University of Maryland Laurel Regional Hospital conversion to freestanding medical facility, Prince George's County. University of Maryland Capital Region Health, University of Maryland Laurel Regional Hospital submitted a second request for a project change after project approval on this month's agenda. The applicant originally filed for an exemption from certificate of need related to the conversion of Laurel to a freestanding medical center. This second request for a project change is regarding an increase in the project's budget. Program Manager and CON Analyst Eric Baker will present the staff recommendation. Go ahead, Eric.
Good afternoon, Chairman Sargent and Commissioners. Thank you. As just said, the second request for a project change after a project approval for an exemption from CON is for the conversion of the University of Maryland Laurel Regional Hospital in Laurel, Prince George's County to a freestanding medical center. The applicants are 2 hospitals operated by the University of Maryland Medical System, first being the University of Maryland Capital Region Health, and the other being the University of Maryland Laurel Regional Hospital. The project, as originally approved by the Commission in September of 2018, permitted Capital Region Health to convert Laurel Regional Hospital to an FMF, operate under the name of Laurel Medical Center. The total estimated budget at that time, which was approved, was just over $53.2 million. In July of 2022, the Commission approved an $18.4 million increase in the total project costs. Capital Regional Health now requests an additional $6.7 million increase in the total project cost, which they attribute to the addition of a pedestrian connector bridge now being built, delays in the delivery of materials due to supply chain backlogs, new design errors, and obviously inflationary increases in the cost of materials and products from the original construction estimates. The total cost of the project, Commission approves this second modification, will be $78,360,714. The applicant will finance the cost of this project with bonds, interest from the bonds, cash and grants. The Health Services Cost Review Commission reviewed the updated financial tables submitted in the second request for post-approval project change and had an opinion that while the projected operating results will be fine. And as long as the University of Maryland is willing to support the request, the project is fine to move forward. Staff reviewed the modifications in the second request for project modification and analyzed whether it remained consistent with the state health plan, whether it was still in the public interest, and will it maintain adequate delivery of emergency services. Staff recommends the commission approve the second request for project change based on staff's conclusion that the proposed project is a permissible modification as it does not include material changes to the nature of the project, the location, or the immediate capacity. That this requested change would not alter the findings that the commission made both in 2018 and in 2022 concerning the need and the positive impact of converting the hospital to an FMF. Representing the applicant at this here in the room is Tom Dane, counsel for University Capital Regional Health, and also on Zoom is Mike Brozek, Chief Financial Officer for Capital Regional Health, Rajesh Stever, VP of Real Estate and Property Management for the University of Maryland Medical System, and Lori Potts, Director of Planning, Development, and Construction at University of Maryland Medical System. I'll be happy to take any questions at this time.
Thank you. Why don't we start with this motion? Do I have a motion to approve the second request for post-approval project change, University of Maryland Laurel Regional Hospital conversion to freestanding medical facility, Prince George's?
I move.
Commissioner Wozinski has moved. Do I have a second? Commissioner Wood seconds. Great. Are there any questions or comments? Commissioner Boyle.
This is a question. It indicates that the GBR is expected to increase. Is that because of this increase? I'm just a little confused about that.
I think the GBR will be maintained as established and will only increase based on whatever changes HSCRC would normally make over the course of the project, but it's not going to increase because of this project.
Okay, that's what I couldn't quite understand. Okay, makes sense.
Are there any other questions or comments? So this round is pretty much inflation.
Yeah, there's a little bit of a project change with one additional construction change, but it's mainly due to inflation on top of what already was previously submitted.
All right, if there are no further questions, I will call the question. All in favor? Say aye. Aye. Are there any opposed? Now you have your motion, your second request for post-approval project change. Thank you.
Mr. Chairman, may I just remark briefly?
Yes, sir. Go ahead.
On behalf of the University of Maryland, Capital Region Health, I just want to thank the staff and commissioners for their continued attention and work on this project, which is scheduled to open in June.
Thank you.
Thank you.
Pretty impressive facility. If you haven't had a chance to see it, perhaps the university can organize a little tour when it opens. I think the first FMF that was approved, a significant project, and I think it will serve the needs.
Going on to agenda item number 6, MDPCP Advisory Council reappointments and nomination. The Maryland Primary Care Program, MDPCP, is a key initiative under the total cost of care model that provides funding and support for the delivery of advanced primary care. In January 2019, the Secretary of the Maryland Department of Health requested an advisory council to be convened by MACC to serve in a consultative and advisory role to the Secretary and the MDPCP Program Management Office. Nina Oniabu, Program Manager in the Innovative Care Delivery Division, will present several reappointments and a nomination for commission consideration.
Thank you, Mr. Chair. Good afternoon, Mr. Chair and Commissioners. Today, can we move to the slides, please? Thank you. So today I will be presenting you with 5 reappointment considerations and 2 nominations for the Maryland Primary Care Program Advisory Council. Next slide, please. The MDPCP is a voluntary program that supports the total cost of care model in healthcare transformation by enabling primary care providers to have an increased role in preventing and managing chronic disease and reducing unnecessary hospital utilization. Next slide, please. Key council activities include making recommendations for inclusion in the state's annual report to CMS on the MDPCP, considering operational improvements to the MDPCP, and gathering data from MDPCP participants and beneficiaries to support issue research. Next slide, please. MHCC provides administrative management and support services for the council. Some staff responsibilities are convening the council, selecting representatives, and making recommendations and reappointments in collaboration with the PMO and the HSARC. Next slide, please. The 5 reappointments include 2 advanced primary care representatives. Dr. Michael Barr is a former MHCC commissioner with over 30 years of healthcare-related experience, and Dr. Rebecca Berenson has an extensive background in primary care and providing policy analysis on healthcare delivery issues. 1 health system representative, Dr. Scott Berkowitz, is the Chief Population Health Officer and Vice President of Population Health for Johns Hopkins Medicine. 2 primary care clinician representatives, Dr. Nkema Keke serves as the CEO and President of Medical Links, a specialized healthcare advisory and management services firm. And Dr. Michael Riebman is a founding member and current president of Maryland Primary Care Physicians. Dr. Riebman also serves as co-chair of the MDPCP Advisory Council. There are 2 nominations. 1 Maryland Health Association representative, Laura Russell, serves as Director of Healthcare Payment for the MHA, and 1 private payer representative, Brian Wheeler, is Vice President of Provider Collaboration and Network Transformation and leads CareFirst Blue Cross Blue Shield's provider and network-related business functions. Next slide, please. We recommend that the commission approve the reappointments for Dr. Barr, Berenson, Berkowitz, Okeke, and Riebman, and the nominations of Ms. Russell and Mr. Wheeler. Next slide, please. Next slide. This table is a current list of council members. The next few slides provide a brief biography of the nominees and reappointment candidates. I've come to the end of my presentation, and I'm happy to answer any questions this time.
We start with a motion. Do I have a motion to approve the MDPCP Advisory Council reappointments and nominations? Well, is there a second?
Second.
I'll let you have the next one. Great. Are there any questions? I have a question. It doesn't relate to these individual nominees. Who are great. I didn't have any concerns. Can we look though when we're coming up for reappointments? How do we determine like if they're, I mean, sometimes you have folks that just don't do anything, right? Or they don't come, or they don't show up. What's our criteria where we would not renominate somebody who wasn't very involved
So attendance would be the key criteria for not moving the person forward that wanted to be appointed. There are instances where people, I've served 4 years, it's enough, I don't want to be reappointed. In the particular case, this year, the 1 person left the organization. Consequently, another person was nominated by that organization to serve. But the nominees, the reappointees and the nominees all are significant contributors to the work groups, to the council's work.
I was just going to say, we do have a charter which states the term limits for different people. So all of the reappointments were because they were coming up to the end of their term, and then we obviously reach out to them to see if they're interested in continuing for the nominations, as Ben mentioned, those were both replacements for people who are no longer at that organization. So the organization is mandated a spot by, in the charter. So those were, for example, the Maryland Hospital Association has a spot defined in the charter. And when the prior representative left, then we have a new nomination, the same for the private payers. They have a spot in the charter.
No one else has any questions based on my question or any other comments? I will call the motion. All right, all in favor, say aye. Are there any opposed? I apologize, I will pause a little longer for the ayes for those online. I didn't hear any opposition though, so motion passed.
Thank you.
Agenda item number 7, legislative update. Tracy DeShields, Director of Policy Development and External Affairs, will provide us with a legislative wrap-up. Legislative session ended on April 10th. She will review the bills that were a priority for MACC, the post-session obligations, work on our plate over the interim. And I suppose if we still want to meet at 8 o'clock on Thursday morning to have a call, we still can.
Yes, so no more calls at 8 o'clock on Thursday morning. So we didn't have to do quite as many. Which is always good. So good afternoon, everyone. So I'm going to give you a presentation, our legislative wrap up for the 2023 legislative session. It's been about a week and a half since the legislative session concluded. Next slide, please. And just a few fun facts and a couple of comments. So the session ended April 10th, as the chair mentioned, at 12 midnight. In the Senate, I think they, like whatever bill they were working on, they passed it at like 11:59 p.m. No one ever wants to be at 11:59 p.m. For 3 years in a row, the health department had bills that passed it. And I remember the times exactly, because you're on pins and needles. 11:58 p.m. And one was, I think we were 11:59 p.m. We were like, not sure, did it pass? And so the next day you look like, oh my God, it passed. Couldn't believe it. But anyway, yeah, so you never want to be that person waiting for that bill to pass at 11:59 p.m. And so a little excitement in the House. Some Republicans walked off the floor, but they walked back in because they walked off the floor for a minute. It was 11:58, so they had to come back in to close session. So it's a little bit of drama, but not that much. Anyway, but I think overall, everyone would say from the executive branch, the governor, and the legislature would say that this was a successful legislative session and a time to reset, where I think they want to be a little more cooperative with the legislature and communicative. And I think the legislature appreciated that, especially leadership, because major decisions have to be made and it can be very difficult. So the number of bills introduced in the Senate, and this includes what they call bond bills and resolutions. The Senate was about 1,300 plus bills. In the House, almost 1,700 bills. The bills passed actually 810, and to date enacted, meaning they were signed into law, 93. So our next bill signing date is actually Monday, April 24th. Next slide, please. So I'll just give you sort of a brief overview of some major legislation. The big thing, obviously, is passage of the budget this year. We came in at $63 billion for the state for fiscal year 2024. Included in that $63 billion budget is a $5.1 billion for projects in the capital budget, and as well as $900 million for Blueprint for Maryland's Future Fund, That's the 10-year education reform fund. We were able to maintain almost 2.85 billion in cash reserves, which includes 2.5 billion in the rainy day fund. And then 351 million in the state's general fund in the surplus. That's the surplus. So actually the budget was $1 billion less than $1 billion less than last year's 2023 budget that was passed. And the legislature historically has only had the power to decrease the budget and make recommendations. And so this was the first fiscal year in 100 years that the legislature actually has a little more authority when it comes to the budget. They were able to increase, decrease, and move funds around. So before they could still move money, but they could only decrease funds and make recommendations. So they have to stay within the budget. And so like if they want to increase money in one area, they have to decrease it somewhere else. So that's kind of how that would work. And this was the first fiscal year. And I think both on the legislative side and the executive branch, maybe the executive branch, because it's new, didn't really realize, except for the Department of Budget and Management, probably they were a little more on edge. The legislature's budget office also as to how this might work. And I think all sides would say that the lines of communication were very much open. So I don't think there was really any acrimony with regard to certain budget objectives from the governor and the legislature. So I think there were probably more compromises than one would expect for this year. And so next slide, please. Just some major legislative highlights. So some of the major areas that the legislature focused on, certainly safeguarding reproductive choice. So there will be on the ballot in 2024, there'll be another referendum to make a constitutional amendment to protect reproductive rights in the Maryland Constitution. That passed a lot of floor debate for various reasons, but it was a debate and then just like comments on the floor for it. But I think it passed without consequence. And then a bill that we were involved in, Senate Bill 786, House Bill 812, protecting privacy of reproductive health information. This would prohibit violations of patient privacy and imposes criminal penalties when information is wrongfully disclosed by any healthcare provider. So this bill, highly technical bill, lots of comments and amendments. So I think they came out with a strong bill, one that certainly we will be involved in, and I'll talk about that in a couple minutes. Then there was cannabis reform. This one, obviously, in the last election, 2020, there was a referendum to legalize cannabis in Maryland. So they created legislation to create an infrastructure for the cannabis marketplace, if you will. Again, a lot of floor debate, a lot of compromise. I think one of the most controversial ones is that medical dispensaries, they wanted them to be grandfathered in, and that was a huge no that went down. I think there were a couple amendments around that, but everybody, it's just a level playing field, so everybody has to come in the same way. And obviously, there were also some regulatory changes, beefing things up with regard to regulating that industry. And certainly some criminal, but we'll have to see. I'm sure there'll be constant updates and amendments to criminal laws, especially around intoxication, where you can smoke it, things like that. So I would think. So we'll see. So becomes legal officially July 1. Next slide, please. And then certainly another area is improving public safety. Oh, sure.
I'm sorry,
Commissioner Jensen.
just to clarify or confirm for me, there was no change to any of the banking regulations related to cannabis, correct?
Correct.
So you can sell, you just can't put the money in the bank.
There you go.
That is, would
We'll
those
put
be?
it in money
That's
market.
primarily a federal issue.
So-
Yes. Yeah. So, but there were no changes around that. So in the other area that was a big discussion on the floor, improving public safety, and that is obviously shielding public spaces from gun violence, storing guns safely. Those bills passed. There were some consternation from some legislators about the bills and trying to sort of maybe moderate them a bit. Votes or motions withstood that, so there were no changes. So the bills, I think, were enacted pretty much as introduced. And then the governor had a pretty for his first term, first session, came in with a 10-point legislative package, which is pretty daunting. Most governors come in with maybe 1 or 3 items that they absolutely want to have passed. But he came in with 10 and all of them passed. And some of the ones are of interest of note. The SERVE Act, this is where it creates for kids coming out of high school, first year, like if you wanted to do a gap year or something like that, you can do a year of service and you would get paid for that service. And we actually now have, well, we do have what's called, I think it's the Volunteer Corps, the Maryland Volunteer Corps. Hadn't been very active, but now that's sort of been enacted. So we'll see how that goes. So I think there was a lot of excitement about that. Also accelerating, getting to the $15 minimum wage. A bill with regard to hiring and retaining teachers and expanding economic opportunities for low-income families. So a lot of that, the expanding economic opportunities essentially centered on making permanent, like earned income credit for taxes for people at various income levels. He also introduced a couple of bills related to people who are in the military, tax deductions, and guaranteeing for the National Guard members healthcare. And like a $60 subsidy or something like that with regard to insurance copays. So I think for him, he's probably pretty pleased to get, even though there were probably compromises and it wasn't exactly all that he wanted, he could claim, I put in 10 pieces of legislation and I got them all. So pretty good. Next slide, please. Now to the nitty-gritty. Okay. So this year, MHCC, our 2024 budget appropriation, $36,693,921 special fund appropriation. Now, $1 million of that, 36 million, is general funds, which is slated for the Patient Safety Center. And that's the one that we dole and manage out to them. It also includes 12.5 million for the trauma fund. And I'll just mention, I have under budget actions. So there were 2 items that were included in the budget bill that pertains to us. There's $100,000, which has been restricted in our budget. So we can't use it And this was contingent on the passage of Senate Bill 786 or House Bill 812, which dealt with protecting reproductive rights. And so what we are required to do is to submit regulations around health information exchange and putting in guardrails, if you will, to protect that health information. So in other words, what we're protecting is someone who may have gotten an abortion in Maryland. They might be from another state that where abortion is now illegal. Maybe they were even prescribed certain medications, things like that. So that information, we have to institute regulations that information would be blocked from being shared among different health information exchanges. So there's no access to that information.
Does that mean that providers who may see a woman in an emergency room might not know of a recent abortion or other health related event that's reproductive in nature?
That's a good question. That could be, yes. Yes.
I'm not an expert in this area by far, but it seems like that might lead to some adverse outcomes down the line for some of the women.
Right. But I mean, I think the goal of this bill, there was another bill that passed in judiciary that sort of dealt with or like the criminal aspects of patient information being protected, health information being released. And so I think in this instance, the idea being that you really sort of want to protect providers who may be providing healthcare services that could be perceived to be around reproduction, right? And the individual could be from another state, like I said, where maybe it's illegal or people would construe it to be illegal. And then that would open up that provider to maybe criminal liability in that state. So that's what the goal of the legislation is. And part of what we're charged with doing, as well as the health department also has a charge, because under that bill, it creates they call the Protected Health Information Commission. And that commission, under the leadership of the Secretary of the Department of Health, will define what the information is to be protected, if you will. And so we have 9 months to come up with regulations, and they actually have 90 days to come up with some sort of regulations to put in place. I think because of the work that we've been doing in this area around health information exchanges and everything like that, you'll hear more about this later, that we're in a really good spot. And so this particular task wasn't onerous to us. It was just a matter of we just have to add it in. Now we just have to wait for the department to do its part.
That $100,000 tied to anything, or was it just
It's our budget. It's not really tied. I mean, it's just, it's 100,000 out of our overall appropriation.
I guess I was saying it's not for a particular task, it's just they pulled 100,000.
They put it there, they fenced it off until we provide them with information that we've done the regs. And I'm not sure if this is one where they can say, no, we don't like it. I'm not sure. In some instances, even if the legislature says they don't like it, we've done the task. You don't have to do anything more. I'm not sure if this is that situation or not. So, but
Hopefully somebody somewhere felt strongly enough that they wanted to have
Well,
an incentive for those things getting done.
correct, yes. So, and then, yeah. And then the second item, can you go back a slide, please? Thank you. So the second item would require us, MHCC, to submit a report on criteria for allocating $9.5 million trauma facility funding. And then we have to submit that criteria to the legislature 45 days before the funds are released from the dedicated purpose account. So I don't know if we talked a little bit about the trauma fund. There's a commission on trauma fund, which I'll talk about, that has been established. But during the legislative session, there were issues raised about trauma centers and their financial situation. So the legislature and the governor's office, I think in their wisdom, decided, well, we'll put in, and this is separate from the 12.5 million in the trauma fund, because those funds are very specific and tied to very detailed distribution criteria. The 9.5 million is over and above. It's a one-time allotment. And MHCC is charged with creating the criteria for dispersing those funds among the trauma centers. Could do it, or we could recommend not doing it. So it's a wide berth, but we do have to come up with the criteria to do that. And so right now, that money is put in the dedicated purpose fund, and then MHCC comes up with the criteria on how it's allocated to the trauma centers. So, and then I'll just mention, this is just an aside, another issue. We knew that there was an issue with the Maryland Emergency Medical System Operations Fund. And so the legislature put in 25 million. This doesn't, we don't manage that, that's managed under MIMS. But it is something, it's related to the trauma center, so it is something, and emergency services, so we should be aware of that. They put that in. Next slide, please. So, I think it's been mentioned earlier, or alluded to, the legislative session was extremely busy and productive. And as a consequence, and because we do such great work here, we have tasks to do. So we do have a number of mandate studies to do for this interim. And so Senate Bill 75, it was a bill that did not pass, and it has to do with the treatment of alopecia and coverage requirements. So this was an odd one because it was only, there wasn't a cross file. So the bill was only introduced really in the Senate, but it had a very late hearing after a couple of cancellations or rescheduling of hearings. But apparently, I guess there was a lot of debate back and forth as to what are you covering and why, and it's all cosmetic. And then we know that there are new treatments, prescription treatments, drug treatments for alopecia. So we will receive in the coming weeks a letter asking us to do a mandate study with regard to Senate Bill 75. The next bill, Senate Bill 108. This was a bill that was introduced again in the Senate, no cross file in the House. And this one would require annual behavioral health wellness visits, coverage and reimbursement. I'm not sure all the debate that went on with regard to this bill. I'm not sure that there was a lot of debate. I think it was probably a little bit of a head scratcher. How would you do it? How would you require it? I think it was sort of around the mechanics, how this would all work. And again, we'll receive a letter asking us to do a mandate study on this. Senate Bill 184, House Bill 376. This has to do with diagnostic and supplemental exams, biopsies for breast cancer cost sharing. Last year, I don't know if you remember, but we were asked to just, I think, submit an informal study on this particular bill. The bill was never introduced. It came in this year on breast cancer and the cost. And so we submitted that report and the bill came in this year. It did pass, but there is a portion in the bill or study that was included in the bill that would require us to look at the financial impact of eliminating cost sharing for diagnostic image guided biopsies for breast cancer. So it's kind of narrow, small piece, and they want us to look at that. And then House Bill 1217, Senate Bill 805. This bill, it did pass. It would require Medicaid as well as commercial health insurance to cover biomarker testing. But again, the bill passed, but they do want us to look at the impact of providing biomarker testing. And so we have 2 years in which to that study, almost 2 years, a year and a half probably. And that report wouldn't be due until December 2025. Next slide, please. Next bills, this one deals with, it's one under healthcare workforce. And in particular, this bill, which passed, created the Mental Health Workforce Development Fund. And it would require us in coordination with the Behavioral Health Administration, Maryland Higher Education Committee, Department of Labor, the Career and Technical Education Committee, and other stakeholders, do a needs assessment and regional plan for behavioral health workers, providers at every level. So, and again, a report would be due next year, by October 15th, 2024. And then trauma funding, Senate Bill 493, House Bill 675, commission to study trauma center funding in Maryland. Again, this bill came in as a result of concerns about the trauma funding. And some of this we did raise last year during our budget hearing about the trauma center funding. And so this year, a bill was put in to create a commission specifically to look at that issue. And so the bill would require MIMS and MHCC to co-chair the commission and also for us to staff the commission. And we are to study the adequacy of the trauma center funding and then provide a report to the General Assembly and the governor by December 1st, 2023, this year. So next slide, please. And then nursing homes. So there were a number of bills that were submitted related to nursing homes. This issue has come up before several times now, I believe. Senate Bill 509, House Bill 702 deals with nursing homes, acquisitions, and licensure. The bill did pass. It requires us.
Could someone mute your phone? I think we're picking up some background noise for someone that's dialed in remotely. So please put yourself on mute. Thanks.
So MHCC, in consultation with other stakeholders, okay, so this bill actually requires us to do a report. We do get information or notice about an impending acquisition of a nursing home. And so this sort of kind of codifies what we do anyway, but it gives us a little more specifics as to the information and how we can actually, what recommendation we would make with regard to a potential purchase of a nursing home. So we can provide a lot of detail, which we do now. We look at all kinds of stuff there, financials, quality, current acquisitions that have been made, what they might do in other states, if it's an entity that has facilities in other states, that sort of thing. And we can provide a report, and we are to submit it to the Office of Healthcare Quality. The Office of Healthcare Quality, along with the Secretary of Health, they have to review that report, and no actions around licensing a facility can be made until they review that report and receive it. I think now generally what we have stated is that they would not, an entity that we think might not be very good or strong. In Maryland, we say that they wouldn't meet a certificate of need requirement, but I think with this legislation, we could probably also recommend that they not be licensed. In addition, one of the things that we had included in the bill as an amendment would require that a nursing home was purchasing a facility that had more than 2 beds in a room, they had to reduce them within 2 years of the purchase. So there was some objection to that because it felt like there wasn't a robust policy discussion around that from stakeholder group. So this would require us to have that conversation, basically, to do the study and to submit a report to the legislature around acquisitions of nursing homes where you have, you could have like 3 or 4 beds to a room, and whether or not it should be appropriate that a purchaser would have to eliminate that and go to no more than two beds in a room. And actually, it actually would be consistent currently with our regulations around that anyway, with regard to nursing homes. And then Senate Bill 648. Essentially, this is a nursing home bill as well, but it really deals with electronic health records and information exchange. Essentially, the bill would, it says that a nursing home has to, their electronic medical record provider has to release information to the Health Information Exchange, essentially CRISP, and reinforcing that they can't do it, they can't charge for it, and they're required to release it. It's already kind of in law, but I think it just makes, it's a little more consistent with House Bill 1022, which passed in 2021, which deals with the same issue. Next slide, please.
Can I ask a question?
Sure.
Oh, just on the nursing home, would we get to see the report that's being?
I would think you would, yes.
The recommendation report or the reports that we would submit.
The
OHCQ.
the one that we have to submit by the.
Yes.
Okay.
Oh, yes, yes.
And that, our policy is before we release a legislative report,
Making sure,
we
yeah.
at least, you may feel like we just wave it under your nose, but we usually release it to the commission, present it in November, December, and then after you vote to release it, it's sent to the Office of State Documents, the 2 committee.
Next slide, please.
Next slide.
Healthcare workforce issue. No one advances slides.
Sorry about that. Next slide, please.
It's got everyone behind you worried.
All right, well,
I think you can go ahead, Drew.
all right, so the next slide deals with protected health information. And this was the bill that I previously talked about where we have the $100,000 restricted in our appropriation until we do the regulations around this. And so Senate Bill 786, House Bill 812 was a bill that passed. And again, it creates penalties for the distribution of protected health information. And it would, what we have to do is come up with restrictions or regulations around protected health information, that it can't be released to another, like health information exchange can't send that information to another health information exchange. And actually the health department has probably the bigger lift on this because they actually have to define what the protected health information is. Now, protected health information is laid out and defined in the bill, but they specifically have to like say what meets that what information would meet that criteria. Certainly it would be reproductive. They really have to define it. And then we are to adopt emergency regulations within 9 months around that and submit. And then we have to submit quarterly reports actually on implementation of the bill in fiscal year 2024 and 2025. And we have to have the regulations developed and submitted by December 2023. And then also a bill that passed dealt with dental services. That was a big issue for individuals, Medicaid or people with disabilities, or who don't have particular access to dental services, House Bill 1146. And then this simply would require that Medicaid cover dental services for individuals, but in that the department and the MHCC in consultation with the Maryland Hospital Association, we have to submit a report to the General Assembly about results of a survey and regional needs assessment. So the issue during the legislative session had to do with dental procedures that required anesthesia or some sort of maybe surgical procedure for children, individuals with disabilities, or those with just very difficult needs that might need to be sedated. And so the complaint was that one, anesthesiologists weren't willing to assist dentists to provide the anesthesia, and they didn't really have a place to do the dental service, these sort of specialized procedures. So there were meetings mainly up until almost 2 weeks until the end of the legislative session every Friday about trying to move the ball, having ambulatory surgical centers provide space. We do have, is it 2, Ben, or 3 ambulatory surgical centers in the state where they do these dental services. And so apparently there's significant backlog of patients who need to have these sort of services. So this is like a prime issue, and we're charged with doing a needs assessment survey on this, coming up with a plan. And then lastly, next slide, please.
I hate to go out in that room.
I know.
It's so live out there.
I don't know. Next slide, please. I think there are people listening to that would think somebody would. Hold on. But anyway, okay. So lastly, there were two bills dealing with telehealth. So we had Senate Bill 534, which dealt with the Preserve Telehealth Access Act of 2023. And if you recall, in 2021, there was the Preserve Telehealth bill that passed, and we were required to do a telehealth study. And on that, what happened, the legislature extended the period of time for insurers to pay for telehealth services, in particular, audio only services. This particular bill looks at sort of would be like part 2 of that study, like what essentially has been the impact, the cost with regard to providing telehealth, especially audio only, and especially in the area of behavioral health care. And then following that, House Bill 1148, Senate Bill 582, which passed, which is a robust bill that deals with behavioral health care treatment and access. And in that bill, it establishes a value-based payment coordination pilot program, as well as extends telehealth in the area of behavioral health, in particular audio only. And it requires us, essentially, we're doing the same study under 2 bills. So it would just one study, but it would suffice to fulfill both obligations under both those pieces of legislation. Next slide, please.
You have to hold up your slide. Yes.
All right, well, that actually, I'm happy to answer any questions. That would conclude my formal presentation. Happy to
Seeing Mount
answer any
Fuji, is
questions.
that Mount Fuji?
Huh?
I'm looking forward to seeing Mount. Is that Mount Fuji on your last slide?
Sure, I know. That's like a big, huge thing.
At the end of the session, do we not have a closing thought?
Well, yes, we do. I have a couple. So I have a question for you to ponder. And I also have a joke in commemoration of Earth Day. So I'll start with the joke. So, what did the ocean say to the beach? Nothing, it just waved.
Mr. Lee, if we got to the joke, I didn't hear from you.
And then lastly, a thought for you to ponder. Can you daydream at night? And with that, thank you very much. And I would like to say thank you to commissioners and staff for cooperation during the legislative session. The 8 o'clock calls. Luckily, we didn't have to do a lot of them because this year a lot of bills were crossfire. There's my last slide. So I put as opposed to the end, the beginning, because of the work that we have to do.
The deadline's in December.
This is Commissioner O'Connor. I have a question.
Sure.
Thank you for your summary. It was excellent. I'm just concerned about the protected status of reproductive history in the person. Number one, is it to the point where it's criminal, I guess, to transfer that information in an electronic medical record
Oh,
from one state to another?
Yeah, so there are, as you know, a number of states where, you know, abortion services, even the discussion of them, puts a provider in criminal jeopardy. So here, the idea being that if Maryland is a state where women might come to seek reproductive services, and it doesn't necessarily have to be abortion, but that a doctor that provides those services would be shielded from a criminal action that could be brought in another state because of the treatment that they may have provided to an individual who came from another
But
state.
the provider can ask the patient if she's had an abortion in another state? Or he cannot even ask that question?
I don't, you know, that's a good question about how this would be implemented. And quite frankly, I believe that I believe this question did get raised during the bill hearing. And I am not sure that the advocates clearly articulated it. I think because the issue is more or less.
But if we're so protective of
right, it is.
if we're so
it is a
protective of medical,
conundrum.
isn't that privileged information anyway? I mean,
think
how
it
can
could
it be subject to criminal prosecution if that information and medical record is protected anyway? That's what we're all about, doing this stuff.
It may be that if we need to, we should have it.
I think that
This is a very technical bill.
it is a technical
Yeah,
bill.
I
Make
think
sure
we
we
should, we should.
don't go astray.
Yeah, as opposed to.
All right,
But
just
then
my
would
2
you
cents.
wanna talk about it at some other time? Okay,
We will definitely, and we will have regulations to do, so.
yes,
More to come on that, so.
Right.
review
I
it,
just
review
don't think
it.
any medical history should be protected, so to speak. So that's my opinion.
Thank you.
you're welcome.
Thank you.
You're welcome.
Moving on to agenda item number 8, a presentation on where the cost application status update.
We did finally get.
It looks like there's a decent chance that you'll have a slide deck. In 2017, Where the Cost was launched and has since achieved 4 successful releases despite encountering various obstacles. The team at MHCC is currently engaged in the development of the 5th release. Mahi Kanjat Solomon will present an update on the project's progress. Mahi, you have the floor.
Thank you. Good afternoon, Chairman and esteemed commissioners. My name is Mahi and I'm here today to provide you an update on the Where the Cost project that has been underway for the last five years. Next slide, please. Next slide. Okay, so starting with the background information, and this might be very familiar for some of you. MHCC launched the Where the Cost website for episode of care in 2017. It targets industry stakeholders and practitioners, but most of all educating consumers. And it uses the Prometheus Cooper, which covers about 90 different episode definitions. So the software also stratifies costs by typical care and from that of costs associated with potentially avoidable complication. So the website reports on cost and quality information by hospital, and that is stratified by types of service. So inpatient, outpatient, professional, pharmacy, and then the costs associated with the potentially avoidable complication. PAC rate, and which is the potentially avoidable complication rate, and the readmission rate are reported as quality indicators. Next slide, please. Next slide. So as I mentioned earlier, looking at the release timeline, the first launch was in 2017 with commercial data for 2014-15 and on 4 procedural episodes. The second release was in 2018 in July, covering years of 2015-16 and with an additional design that included an online appeal feature. And the third release, which was in July 2020, included 6 new episodes for the study window of 2016-17. That brought the total number of episodes to 10. So the last release was in October 2021 with additional 3 episodes for the year 2018 and 19, with the inclusion of an outpatient episode, tonsillectomy, and the plan is to also add more outpatient episodes in the future release. Next slide, please. So this just shows the number of episodes per release, and the ones shaded in yellow are the new ones for that particular year. Next slide, please. Where the cost gained recognition from local and national healthcare community, including Health Affairs, Kaiser Health News, and other organizations. And the screens that you see are from the various outlets. Next slide, please. Next slide. So moving on to the communication strategy, MHCC has assigned a communication contractor to develop a strategy to educate consumers as it is one of the primary objectives. So initially it focused on Facebook and other social media platforms for communication and outreach. The team continued to use organic and paid social media campaign on Twitter and Facebook to promote and grow the conversation. In 2020, MACC reevaluated the strategy to tailor the campaign according to Marylanders' health information seeking behavior. So with that, in 2021, MACC shifted the paid advertising strategy and focused on budget on programmatic and search ad. This is to continue the raising awareness and educating consumers on episode cost and quality. So we continue to use data to drive the strategy and refining the ad work, and also ensuring that the campaign continues throughout the multiple years. Next slide, please. So where the cost project faced multiple challenges, and one of this being in 2019, MACC and the vendor attempted to process Medicare data, but there was an irreconcilable data issue that arose, which at the moment was because the episode group had never been used with Medicare data. So at the moment, MACC decided to focus on the commercial data for the time being, and that has been what we've continued to do. And for this release, we are planning to include Medicaid in addition to the commercial data. The project has also undergone various vendor changes. So it started out with HCI3 in 2017, and then we used Alterum in 2017-18, which later on moved to Remedy Partners, which was acquired by Signify Health, and we used Signify Health in 2020 and 2021. And now we're for 2023, we're using Change Healthcare. Next slide, please. So continuing with the challenges, the project also faced a contract interruption. So MACC signed a contract with Signify Health back in April of 2022, which was interrupted within 2 months in June due to the sunsetting of their episode of care division. So MHCC then pursued Change Healthcare, and after negotiation, a new contract was executed, and a data management plan was submitted and approved in February of this year. The project commenced in March and is currently in the process of the input data specification and testing of the data. Next slide, please. So what is included in the current work and what has been done in the past to support this objective? So looking at the near future, the MACC, looking back at what has been done, MACC contracted with On Point Health Data as the new MCDB data vendor back in 2021. So OnPoint was tasked with transferring the Where the Cost website into a new domain, which was completed in June of 2022. Staff participated in the feedback and that was incorporated in the user acceptance testing and the of the production release. Next slide, please. So looking at the current work, the priority is to successfully complete the upcoming Medicaid and commercial release. This is for 2020 and 2021 data. We are also seeking a multi-year contract for the project. As I mentioned earlier, 2020 and 2021 data is currently underway, which means we're planning to update the website in the September-October timeframe. Next slide, please. So considering the future, there are challenges and opportunities ahead of us. So looking at the challenges, the Prometheus Grouper was chosen because it was an open source, but currently because of the multiple acquisition, it has been migrated into a proprietary domain. So currently there aren't any open source products, groupers out there. The ones that we're familiar with, which is 3M and OnPoint, are also proprietary products. Hence, the future of Change Healthcare is unclear because it's currently being under the subsidiary of Optum. So the opportunities is that 3 entities, including MHCC, is using Change Healthcare for the episode grouper with the episode group project. So HSCRC for their EQUIP, this is the episode quality improvement program, CareFirst for their episode program, and obviously MHCC for the Where the Cost, all use Change Healthcare for the work. And all 3 organizations are carefully monitoring the acquisition of Change Healthcare by Optum. So there is a push in Maryland to come up with a Maryland-specific episode product. With that, I conclude my presentation. I can take it questions. Next slide, please.
Are there any commissioners with questions? Is the issue with the groupers, not being open source, is that the biggest thing keeping us from expanding the number of conditions?
No, it's the interruptions with the contract. So last year, like as I mentioned, there have been, the plan was we had a release in 2021 and was planning to do the same thing in 2022, and then between we had the migration into the new environment that is managed by OnPoint. So, and then we had the contract interruption with Signify Health, which led us to going through various cycles of negotiation with Change Healthcare to get to where we are right now. So, and the arrangement is a little different with Change Healthcare because they're familiar with the HSCRC work and CareFirst, but ours is a little different because it's geared towards consumers and we have specific data output that we use for the website. So trying to kind of work with their standard product, trying to come up with a custom format for our need was what actually most of the time.
Thank you. Anyone else? Thank you, Mike. Agenda item number 9 is a presentation, update on compliance with conditions of a certificate of ongoing performance for BCI services for several hospitals. For our last agenda item, Eileen Flex, Chief for Acute Care Policy and Planning, provide an update on each of the 5 hospitals that have 1 or more conditions on a certificate of ongoing performance for BCI service. I think you have the floor.
Good afternoon, Mr. Chair, Commissioners. Next slide, please. Next slide. So these are the 5 hospitals where I'm going to give you an update on their compliance with conditions on the certificates of ongoing performance. The first one I'll go over is Meritus Medical Center. Next slide. There was one condition on this hospital's certificate of ongoing performance. This condition pertains to holding meetings at least every other month for the purpose of conducting interventional case review that includes physicians, technologists, and nurses care for primary PCI patients. So I'll just refer to this as interventional case review meetings for shorthand. The hospital has completed its requirements for the condition. It's submitted the information for 2 years. It's twice a year that they submit the information. Each time it's shown that the meetings have been held 6 times a year. The people that should be attending the meetings are attending the meetings. So we are recommending, as I'll say at the end, well, actually, so the executive director has decided, this is not an action item, that we're going to release the hospital from this condition. Next slide. So UPMC Western Maryland Medical Center also has a condition for holding interventional case review meetings. And it has a second condition for holding monthly multiple care area group meetings. And this pertains to looking at that system of care from the time a patient needs an EMS transport, showing up at the hospital, being in the emergency department, going to the cath lab, post-acute care. So kind of that system that exists. And those meetings are supposed to include certain people that happen each month. The hospital is complying with that second condition. It's provided the documentation that those meetings have been held monthly. And there's only one exception in calendar 22, which was in November. And what they did was they just held over the material from November and did it in December. So that's good enough in terms of compliance. Again, the executive director decided that we would release them from this condition. Next slide. U of M Capital Regional Medical Center is the third hospital. It has the same conditions that I mentioned for the other hospitals. The one in terms of the case review meetings, where the meetings need to be held every other month. Again, the hospital has been holding those meetings. It provided the documentation of those dates and the attendees. It's demonstrated compliance with the condition. It's also needed to show that it's compliant with the multiple care area group meetings, looking at that system of care for the PCI patients. Again, it's provided the documentation. The appropriate meetings are being held each month with the appropriate attendees. It's in compliance with that condition. And then there's a third condition here, which wasn't placed on other hospitals, which refers to maintaining a formal continuing education program. They needed to just submit information on the activities and the staff that are participating in those activities. And the hospital has provided the detailed information in terms of continuing medical education, the dates, the participants, the topics for the 2 years. So again, this hospital, it's demonstrated compliance with the conditions for 2 years, and the executive director has decided to release the hospital from the conditions. Next slide. Adventist White Oak Medical Center has 2 conditions. One is for the interventional case review meetings, and the other is for the multiple care area group meetings. The hospital has provided this information for 1 year. So twice during the year, it submitted documentation showing compliance. This hospital is a little bit different in that it had 10 meetings for that interventional case review, which sounds like a lot more and is a lot more than the requirement of 6 meetings a year, just every other month. But it actually uses the same meeting for both requirements. And so 10 meetings is substantial compliance. For the other one, they should be meeting every month. They did have to cancel 2 meetings, but that is pretty close to what we need. And sometimes meetings do need to be canceled. So we're not recommending release at this point. We feel like it should kind of be a standard. Expect it to be about 2 years of showing compliance with the condition. Next slide. Lastly, we have Suburban Hospital. There's just one condition on this hospital, having those interventional case review meetings. Again, the hospital has been providing the documentation in terms of the dates of meetings and the attendees. It's demonstrated compliance for about a year, slightly longer, January 2022 to January 2023. Next slide. So this just notes, as I said during the presentation, the executive director decided to release 3 of the hospitals: Meritus Medical Center, UPMC Western Maryland, and U of M Capital Regional Medical Center.
Thank you. I have one question. If for these meetings, I mean, we've released the condition, which means we're not monitoring them, but when they are going to come back for a renewal of their certificate, we'll be looking at whether they've been holding the meetings at that time.
Yes, so the hospitals still need to be providing
Just,
tracking the information and they'll provide it later on anyway. It's just a matter of not having to submit it as frequently.
which makes sense.
Right. Okay, thank you.
Thank you very much. I guess you say that any of the commissioners online have questions? Good. With that, we've gotten to agenda item number 10, the overview of upcoming activities.
So I want to thank all the commissioners for their persistence on our rather lengthy meeting, but we did get through almost by 4 o'clock, which is good for me because I have a doctor's appointment. But I'm going to make that. But looking forward to May, we're going to have a couple ICF CONs to consider. We do have very likely, again, the modifications. You know, inflation is wreaking havoc on previously approved projects. We expect a modification for the tower at Adventist Health in Shady Grove. We will bring forward a CON application to reestablish a NICU in Prince George's County. Historically, there has been one at Capitol at Dimensions. When that hospital was relocated, they closed the NICU. Now they are ready to open a NICU at Capitol Region, and that will require CON action on our part. We do plan to bring forward proposed regulations for healthcare for acute care of hospitals. That's been a regulation that Eileen's team has been working on for a good year now, and we're just ready to bring it forward for public comment. And lastly, we are resurrecting a report that we had done from about 2002 through 2012 called the State Health Expenditure Account, which tries to give a reckoning of all healthcare spending in the state. We had abandoned it because of funding concerns back in the last decade. Our funding picture is a little better, and there's generally interest in knowing, put a dollar figure on how much is spent in Maryland on healthcare. We think it's around $68 billion, but clearly there's an interest in how that's distributed among healthcare payers and healthcare providers. We're going to make another run at that. I want to note, Ken's team has been working on that with our project management organization, Friedman Health. It's not going to be perfect the first year, but we really think as we move through the total cost of care effort, that coming up with a metric that everyone can agree on in terms of total spending would be helpful for decision making moving forward. So we'll look forward to seeing that. Don't expect to be perfect the first year, but it's resurrecting an effort that took a good year to implement. When it was in full operation, meant we lost some of the information, the data sources in the 10 years since it's not been done. And we have had to derive other alternative data sources. So I'm excited to get that going.
How long before it will be perfect?
It will never be perfect, but it will incrementally improve. I think that's what I want to say. Thank you very much.
Any questions or comments? With that, thank you everyone for a good meeting. We went through a lot in a relatively short time. Yes, I'll entertain a motion to adjourn.
I'll give a motion.
All right, all in favor?
Aye.
Aye.
All right, it's now over to the gavel strikes.
Do I have to do this? Hey, now we're free.
Safe travels,
Thank
everyone.
you, everyone.
Thank you.
Good news at your doctor's.
Have to go get it tomorrow.
Safe travels.
Appreciate it.